This is a short, informative video on how to perform the Hess screen test. The indications of use for the Hess screen chart are to aid in the diagnosis of underactions and overactions present in incommodant strabismus. These can be due to mechanical restrictions or a neurogenic palsy. The Hess screen provides a permanent and accurate record of ocular movements that can be compared to with subsequent visits to document changes of the deviation over time. The Hess chart is a tangent screen used to map the relative positions of each eye in 9 positions of gaze. The chart includes horizontal and vertical lines that subtend a visual angle of 5 degrees. This image shows a newer version of the Hess chart, where the chart itself includes red LED lights, which the examiner is able to control by using a remote. Older charts, however, require the examiner to use a red handheld torch similar to the green torch that is held by the patient. The Hess chart can be used to measure the eye movements in 15 degrees and, where appropriate, in 30 degrees. In order to perform the Hess screen test, a range of equipment is required. This includes a green torch, which is held by the patient, a RAF gauge used by the examiner to measure the distance between the chart and the patient, a remote, which controls which position of gaze is illuminated on the screen, red-green goggles that the patient wears throughout the assessment, and a recording sheet to record the results. In performing the test, the glasses are placed on the patient so that the eyes become dissociated. It is always key to remember that the eye under the red goggle sees the red light and the eye under the green goggle sees the green light. When the red light is controlled by the examiner, which is the gold standard, the eye under the red goggle acts as the fixing eye, and the eye under the green goggle acts as the indicator eye, which we measure the deviation of. When the patient superimposes the green light over the fixed red light, the position of the indicator green eye is plotted, marking the deviation in each direction of gaze, giving the size of the deviation. Also note that the Hess chart relies on the principles of foveal projection and dissociation of the eyes. The patient should be seated 50 centimetres from the chart. The RAF gauge is a good quick measurement tool for this distance, and it will often be available in clinic. The height of the screen and/or the chair should be adjustable. In our case, the screen is fixed, so we have ensured that we seated the patient on an adjustable chair, preferably one without wheels. The patient needs to be aligned with the central fixation target, and it needs to be explained that they need to keep their head very still and only follow the appearing lights with their eyes, not with head movement. As we had a very cooperative patient, holding her head still was not necessary. However, if the patient had a tendency to adjust their head position, holding their head in a stable position would be necessary. Ideally, you would use a headrest and a chin rest to ensure that the patient remains still. However, this was not available to us on the day. The test needs to be explained to the patient, and they need to be given the green indicator torch. The goggles are then placed on the patient's face, ensuring that they're a comfortable fit and not too tight. The room lights also have to be turned off or at least dimmed.
Morgan, do you want to come on in? My name is Danny and I'm going to be your orthoptist for today. Now what we're going to be using is this machine here, which is called a Hess chart. Now what we're going to do is we're going to get you to look in 9 different directions, and as we do this we're going to be looking at how your eyes move when we tell you to look in these directions. Now to get you set up, I'm going to use this contraption here, which is going to measure 50 centimetres from the chart. So what I'm going to get you to do is I'm going to get you to shuffle your chair on in for me. And getting your nose right up to here, perfect. Now I do just need your nose here, so I'll get you to use your lever just to raise yourself up a little bit. Beautiful. Now staying as you are now, it's really important that we keep our head nice and still and we're just moving our eyes around. Now what you're going to see, these red lights here, what they're going to do is they're going to come and go and they're going to move around on the chart. Now I'm going to control the red light. What I'm going to get you to do is you're going to hold this green torch here. Now as we go around, holding our head nice and still, I want you to move your eyes to get the green light on top of the red light. Beautiful. Now what we're going to get you to do is we're going to get you to wear these really stylish goggles. Now, are you comfortable if I pop these on you now? We're going to make sure the right eye has the red goggle over it. Beautiful. Now that's not pressing in anywhere. Nice and comfy. Perfect. And again, we're just going to measure, just make sure we're at the right distance. Beautiful. Now I'm just going to go turn the lights off. I'll be 1 second.
It is vital that the patient's eyes are lined up with the central fixation target when setting them up. This ensures that they are in primary position and the measurements of the extraocular muscle actions are accurate. Using a chair with adjustable height would make this easier. It is a good idea to get into the habit of putting the red lens of the goggle over the patient's right eye. This is the gold standard method and a good way to have a consistent, systematic approach. For the duration of the test, the patient's distance from the chart needs to be maintained at 50 centimetres. The RAF gauge is the easiest way to check this distance if you do notice the patient leaning forwards or backwards. Make sure that the patient is moving their eyes only and not their head. Otherwise, the results produced will be inaccurate. If required, hold the patient's head still with your hands. If available, the use of a headrest and chin rest is ideal.
Alrighty, so I'm going to move that red light and I just want you to put your green light right on top. Beautiful. And again. Looking down a bit for this one. Perfect. Wonderful. We are all done. I'll get you to pass me your torch and you can take your goggles off now. And well done.
Pictured here is a recording sheet of the Hess chart. The orange dots seen correlate with the red lights controlled by the examiner via the remote control. Each of the dots are specifically located in a position of gaze which assesses certain extraocular muscles of the patient. The primary muscle being assessed in this gaze is also on the recording sheet. When the patient moves the green torch to superimpose their green light on the red light, this is what we as examiners record on this sheet. As the Hess screen is based on foveal projection, the result recorded on the recording sheet is the actual deviation. That is, the position of the field is equal to the position of the eye. On the recording sheet, the normal ocular movements of each muscle from both eyes is given and can be compared to the recorded results to determine the presence of overactions or underactions. There are three main factors to consider when interpreting the Hess chart results. These are positioning, size, and shape. The position of the central point indicates where the deviation is in primary position. The size of the field can determine which eye has the primary affected muscle. The smaller field belongs to the affected eye, and the shape of the chart can indicate AV patterns when there is sloping of the fields. This example of potential patient results shows that the left eye is the affected eye as it has the smaller field of the two. The central point is inwardly displaced in this instance, which correlates to an ESO deviation in primary position. The entire field of the left eye is displaced inwardly, denoting an underaction of the left lateral rectus. A mechanical restriction will show narrowing fields in opposing directions. In this example, the left eye is the affected eye as it has the smaller field and is restricted in both elevation and depression. The right eye is showing overactions in elevation and depression, which is caused by the excessive innervation going to the left eye in an attempt to move the eye, and therefore leading to equally increased amounts of innervation to the yoke muscles in the right eye. This is a mechanical restriction of the left eye. The advantages of the Hess screen are that it provides an accurate and permanent record of patients' ocular movements. This is beneficial as it allows comparison of patients' results and ocular movement changes over time. The recording sheet is succinct, which makes it easy to interpret and is able to be used to explain and educate patients of their deviation. It is easy to perform and the test is not difficult to learn, so it is able to be performed on children and the elderly. All positions of gaze can be assessed and the field can be measured not only in 15 degrees but 30 degrees as well. The Hess chart cannot be performed if the patient has abnormal retinal correspondence, as it is based on the principle of foveal projection. The patient must have normal retinal correspondence, otherwise it will give inaccurate measurements as the subjective angle is recorded, not the objective angle. Additionally, it cannot be performed if the patient has dense suppression, as the patient will not be able to simultaneously perceive the red and grey lights, as they will suppress one, therefore making them unable to be superimposed. Also, if the patient has profound red-green colour blindness, it is not recommended to complete the Hess chart. Thank you for watching our short introductory video on the Hess screen test. Hopefully this has provided you an overview on when you would use the test, the basics on how to perform the test, the principles behind it, how to record the results and interpret the findings, as well as the pros and cons. Thank you.